Hi, everyone. Welcome to our monthly webinar on trending beyond COVID-19. Today's topic is vaccine mandates and related issues. There's been a lot happening in the last month since you last joined us. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare. This session is being recorded. During the webinar, you'll be on mute. Please submit your questions using the Q&A function in Zoom. The webinar recording will be posted on our YouTube channel, and a transcript of the Q&A segment will be posted on our website within the next few days. We'll share these links with you during the session. We have a full hour scheduled today, so there should be plenty of time for all of your questions. Although last time we had so many, some of them we had to answer in writing after the webinar. So we'll try to get to as many as we possibly can today. Allow me to introduce our speaker. Most of you are familiar with him, but if you're joining us for the first time, you'll be happy to know our presenter today is Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and an Associate Medical Director for on-site clinical operations. He's also our lead clinician for our COVID-19 response. And now I'll turn it over to him. Thanks again for joining us.
Excellent. Thank you, Karen. And thanks everyone for joining us once again as we continue to endure this pandemic. And we all know, we see the trend in terms of heading in the wrong direction regarding our ability to conquer COVID. And we're going to get into that, and we're going to center our thoughts and considerations around vaccine mandates in the workplace as a way to get on the other side of hopefully this COVID pandemic over the next year. And we'll talk about some grim facts, but we'll also talk about some benefits of the vaccine still, and we'll hopefully get to the messaging that will resonate with your workforce as we endeavor to increase vaccination efforts. So you are likely familiar, if you're joining us again, with our format for this presentation. It begins with the clinical business case, straightforward. What clinical trend should you be considering in your workplace? We'll go into the causation or the causal pieces of why that trend exists and why you should be considering it. Then we'll talk about some thought leadership around how we can think differently to help our workforce and protect them from this COVID pandemic. And as we trend out some interesting happenings in the news, we'll dive into how they're relevant for your strategy in the workplace from a protection standpoint. And we'll talk about the mechanics of it. And today we're going to get a little heavy in the pathophysiology or some of the immunology. And I know we've done that before, and I think everyone is hung with this. So I'm anticipating that we're going to have some fun today in regards to getting down to some of the questions that we've had to answer for our EHS folk, specific to vaccinations and immunology around COVID-19. And then finally, we'll conclude with some brief best practice around messaging what has happened from a trend standpoint in the business arena across the US and abroad. So without further ado, getting to number one, the business case. Obviously, you've probably guessed it, and we talked about this last month as well. That's why we're reiterating it again and talking on from a slightly different perspective this month. But mandating the COVID-19 vaccine in the workplace to protect your workforce was what we proposed last month, right? The best way to mitigate morbidity, mortality, and some of your business risks. But as you know, the trend that we see in the workplace as well as across the communities in America is trending in the wrong direction. And so it begs the question, is mandating a COVID-19 vaccine in the workplace something we should be considering because there may or may not be enough efficacy or reason for it, right? So is there still a strong business case for mandating the vaccine for COVID-19 because of, in particular, the breakthrough transmissions that we've been seeing with those who have been fully vaccinated. So we'll dig into that. As we dig into it, however, we have to start with where we left off last time in terms of the Delta variant sweeping the globe, looking at now over 4 million cases in a week worldwide from the Delta variant, right? And this is current data last week. There's been over 203 million cases of COVID at this point worldwide during this pandemic. And that's recorded cases, right? We understand that there may be far greater number of individuals infected because we don't have reporting throughout the world sufficient to capture and accurately depict the impact from COVID. As we zero in on the US, we want to specifically single out, I'm in Chicago, so we'll single out Illinois, and we'll look specifically at deaths because that is an important metric that we have looked at time and time again, and we want to revisit as a strong motivator for promoting vaccinations, right? If we look at deaths in Illinois alone, over 62,500 deaths have occurred as a result of 1.53 million cases of COVID, right? The majority of those sitting in Cook County, where I'm located in Chicago. And so when we consider other states, we can look at California, 65,000, almost 66,000 deaths, 4.45 million cases, all right? So these are staggering numbers. And if there's any question about the impact of these deaths from a total number standpoint, let's consider this. According to the U.S. Transportation Bureau of Transportation, we can look back at pre-pandemic where the number of individuals who had a fatal car crash, as we know, is one of the leading causes of traumatic death, right? 33,000 individuals lost their lives in 2019 from car crashes. And obviously, we know that's been a focal point from an overall safety standpoint in the US for decades. However, what we just examined is that in Illinois alone, right, we had nearly just as many people who have died from COVID thus far as all killed in car accidents in a year in the US. Obviously, in California, that number is actually nearly doubled, right? So twice as many people have died from COVID than car crashes in a year. So that just allows you to contemplate the impact that COVID has had, because there are some who still doubt the impact of COVID, right? And we need to have these figures so that we can communicate effectively to our workforce the impact that we are actually observing from a objective data point, right? We're not subjectively suggesting anything other than the real numbers here for our workforce. And so as we talk about the mandates and the trend upward towards mandating workplace vaccinations, we want to understand what's the cause for employers jumping on the mandate bandwagon, right? Obviously, preventing poor outcomes is one of them, but we've seen this play out since we've met last time, that FDA has now approved Pfizer, right? And as soon as that happened, we saw in the headlines that we had a myriad of companies now authorizing or mandating the COVID vaccine, right? From a company, we presented on companies like Disney prior to the Pfizer approval, mandating the vaccine for the workers, Walmart doing the same. But now we're talking about hundreds of companies that have across the board mandated a vaccine, and it's a clear trend that we believe will continue because it's becoming the primary way to prevent poor outcomes and mitigate risk in the workplace. So let's look at how we're doing in the US briefly here. So when we talk about the impact now from COVID and put that in perspective, obviously a total number of cases here, 39 million with a case rate of 314, total deaths, 630 37,000 deaths, right? But if we look down at the bottom here, we can see the 7-day case rate per 100,000 individuals. Okay, we're hovering. If you look at the hardest hit states, they're between 550 and 600, just under 700 cases per 100,000. So now let's put that in perspective, right? If we look at where we were this time roughly last year, this data coming from October of last year, before the vaccine was available and distributed, we saw a case rate on 7-day average down to 45, almost 46, and between that and 72, nearly 73. Again, that's where we were in the hardest hit states before vaccines were distributed. During our vaccination period right now, with the number of vaccines that have been fully administered in the US, we're nearly 10 times that number, right? So that's concerning, right? And you will hear this message echoed to those perhaps in the workplace that are saying there's no compelling reason to get vaccinated because it's not working, right? And that's only partially true, right? And from a clinical standpoint, we know that the vaccine does not fully prevent, right, transmissions from happening. We talked about this before. We presented on the data from Israel showing 39% efficacy at preventing transmissions, right? There is more data coming, will be published soon from CDC looking at the efficacy of transmission prevention. But thus far, we know that it's only partially effective at transmissions. However, as we talked about last time, we want to focus in on loss of life and severe illness as a main reason to get vaccinated and prevent the burden of illness from a both health cost standpoint as well as business risk. And we'll dig deeper into these numbers here shortly. Let's look at now seropositivity. Again, another driver and a reason for, on both sides, consideration of to mandate a vaccine or not mandate a vaccine. We haven't looked at seropositivity in quite some time during this presentation, but we want to refresh because what seropositivity, as you may recall, tells us is on average, right, what is the estimated number of people that have been infected in a specific geographic. And in this case, CDC publishes this data from studies that are conducted by both public and private laboratories, taking samples that individuals provide for various reasons and testing for antibodies to COVID or SARS-CoV-2, right? And so let's zero in on some of the states that have high seropositivity so we can compare where they are now relative to where we were before. So let's look at Ohio. It's estimated that 33% of the population has been infected with COVID-19 in Ohio, right? These are huge numbers, right? And we know that when we consider, we'll talk about as we consider where we're at with our current trend, knowing the seropositivity estimates are important because that will inform our strategy moving forward and be compelling as to why we need to still focus in on vaccinations. If we look at another state here, Mississippi, 33.8% positive rate. So again, a third of the population in that state has been infected with COVID-19. Texas, similar number, right? 31.9. So we're talking significant number of the population having at some point contracted and recovered from COVID-19 in these states hardest hit. So as we look in general then at a 7-day rolling average cases per million of individuals, we want to compare ourselves to how we are faring compared to our neighbors across the pond that are experiencing spikes as well and have been. So if we look back to where we started in this month on August 1st, we can see where, and we presented a little bit of this data last time, the UK having a dramatic spike. That was a result of their single shot strategy. to vaccinate their individuals, likely, right? And a decline as we were on a sharp incline in terms of number of new cases. As we fast forward to today, at the end of the month, now September, we're neck and neck with the United Kingdom that has seen another bump up in their numbers. And we're still in the US dramatically increasing on a 7-day rolling average, the number of new cases, right? So it's quite alarming. If we single out the US here and we look at the estimate, right, of reproduction in the US, remember that R naught that we talked about months and months ago, R naught being, as you recall, the number of individuals that are likely infected by one person with COVID-19, that R naught early on was as high as 3.5. We're talking the beginning of 2020. Now it diminished, but now is higher than it's been since March of last year, over that 1.5 number. So this is alarming. Again, with the number of individuals fully vaccinated in the US, we're seeing an R naught reproductive rate as a result of Delta higher than it's been in over a year and a half, right? So our strategy has to change in terms of our approach to protecting the workforce. If we look at then confirmed deaths as of today, we are above the United Kingdom in terms of deaths. Now recall, they were above us in terms of cases, right? Neck and neck, but our experience and outcomes in the US dramatically different. This is why we get vaccinated, right? Because the UK has higher rates of vaccinations than us, even though they did a single dose strategy, right? That single dose was protective and helped them experience less death than we did here and than we are in the United States. So this is a comparison of unvaccinated population and vaccinated populations, right? And so this is the information we have to share with our workforce. This is the information that we have to consider when we're talking mandating a vaccine in the workplace, because this is the efficacy we want in terms of outcome played out at a macro scale amongst nations. So as we go on to the next point here, we want to zero in on mandating the vaccine and knowing your workforce, right? We want to understand who in our workforce is likely to be vaccinated, who is unlikely to be vaccinated, and why, right? Because that's going to help us in communicating our message of please get vaccinated to help prevent loss of life and severe illness, morbidity as well, right? So let's zoom into this data. And as we do, we all must get level set again. That herd immunity is not happening, right? We talked about this before. We recognize that in order to even think about or fathom reaching herd immunity, we would have to reach levels of vaccination upward of 95%, right? And that's a number that we've only seen with regard to illness like vaccinations for measles, mumps, right, and rubella. So as you know, those are mandated across the board. If you want to participate in public school in the US, that's why those rates of vaccinations are as high. The UK in 2015 had the eradication of rubella, right? And that was announced by WHO because they reached levels of 95% of their population vaccinated against those particular illnesses. So for us here, that's not likely ever to be the case for COVID-19 unless we have, similarly so, a national mandate for vaccination. However, we can still impact our experience here as we consider workplace mandates for vaccination. So where are we right now nationwide in terms of vaccinations? Let's look at where we were last month. We were at 57.9% and 49.7% respectively for one dose and fully vaccinated individuals. Fast forwarding to today, those numbers are up. So we're at 61.8%, at least one dose, and 52.4% for fully vaccinated. And that's for all of the populace. If we are looking specifically at those who are eligible to receive the vaccine, a little rosier picture in terms of one dose, upward of 72%, and fully vaccinated at 61.4%. And this number did bump up. We saw a little bit after the FDA gave official approval of full approval of the Pfizer vaccine. Let's look at then breaking down the demographics of who's getting vaccinated and in our workforce. And we can do that through the lens of data coming from Kaiser. Looking at Kaiser's data, the large clinical institution, they looked at and surveyed parents, and they wanted to make some comparisons of who's getting vaccinated at a large scale, right? And if we look at parents and non-parents, non-parents are 71%, parents are 61%. And as we articulate these individuals further in demographics, 40 and older are more likely to be vaccinated. So again, we're putting this in the perspective of our population in the workforce. As we look at then breaking this down from a household income perspective, it's a clear trend, right? In the higher your income, the more likely you are to be vaccinated, right? And this trend is to the tune of 47%, 58%, and 76% from the 40K, 40,000, just under 90,000 and over 90,000 benchmarks for household income. As we go into education, non-college educated, not as likely, only 50% so, as college degree earners, 79%. Right? As we break down ethnicity, we're looking at 54%, Blacks being the lowest to be vaccinated, Hispanics being the highest at 67%, and whites at 63%. And then finally, we can see a clear breakdown along party lines of vaccinated Democrats at 82%, Independents 62%, and then Republicans 46%. So again, we report this not to introduce any partisanship with regard to our approach to our protecting our workforce, but by understanding our workforce and the demographics that are making up the propensity towards vaccination and not, we'll know as we contemplate a potential mandate how the response will play out based upon the makeup of our workforce. And that's important so that we can be prepared in those communications and be very responsive so that people are hopefully put at ease on their concerns germane to the vaccine itself. So let's continue to look at some of these demographics as Kaiser has broken out the likeliness to be vaccinated on several levels. So now let's look at total employed parents, right? And the question was that they asked, as far as you know, does your employer offer paid time off to ... We'll fill in that ... here at 4 different levels. How likely is your employer to provide paid time off? And they asked all parents employed and getting a vaccine themselves for the worker, only 39%, right? Recovering from side effects, 35%, taking your children to get a vaccine down to only 21%. And then caring for your child if they experience vaccine side effects, 24%. Okay, so again, we're trying to understand what are some of the barriers in our workforce for promoting vaccinations, both for individuals themselves, as well as their families, their children. If we look at that breakdown amongst those who earn 40,000 or less in the household, we can see that employer support for getting a COVID vaccine is very low, 20%, right, in terms of paid time off. 20%, 16% from side effects, 8% for supporting your children getting vaccinated, and then caring for your child if they have side effects from the vaccine, 14%. We look at then in the next bracket of income, 40 to 90,000, just under 90,000, it gets a little better, 34% support for paid time off for an individual, 26%, 18 and 16% respectively for caring for helping your child get vaccinated, and then time off for taking care of your child. Now, in the highest bracket, we can clearly see the trend, right? The higher earners have more support from their employers from a paid time off perspective to get vaccinated. And so is this a causal effect in regards to why we saw previously higher earners being more likely to be vaccinated? Perhaps. There's not enough data here to make that causal association, but it is important to point out that this correlation does exist, even though it may not be causal. And that's why we want to consider nuances in our approach to supporting our employees to get vaccinated and getting their families vaccinated as we continue to move forward here. So again, we reported on this 39% effectiveness is real data from a perspective of preventing transmissions. But again, we want to reiterate that severity of illness, when we're talking about hospitalization, is prevented 88%. If we're talking actual severe disease and death or severe illness that can lead to death, it's 91% effective. And again, that's what we saw play out when we contrasted how we're faring with regard to mortality in the US, COVID related, compared to the UK that had higher vaccination rates, even albeit a one-dose strategy. So as we contemplate then interventions beyond COVID-19, we want to talk about clinical trends specifically. And now this is when we're going to put on our, our clinical hat. We're going to get a little heavy here and some of the trends that have played out, some of the questions that we've received, and we want to be specific in answering so that you further understand some of the questions that you will get from your workforce as we talk about COVID-19 vaccinations and the impacts from a clinical standpoint. So let's look at an advisory, and this is a trend clinically that's played out, an advisory from CDC noting a rapid increase in the use of ivermectin. Ivermectin is a pharmaceutical that is an anti-parasitic. It's used, it has been used for years to help prevent and treat illness. But now there's been a trend towards utilization. If we look specifically, right, during COVID-19 pandemic, ivermectin dispensing by retail pharmacies has increased, and the use of even veterinarian formulations that are over the counter have increased. And so FDA is cautioned against potential risks of use of ivermectin. And so we get this question from our workforce, and we want to be able to answer it in a way that at least informs them of whether or not ivermectin is a recommendation from a clinical standpoint. Obviously, FDA has not approved for such use for COVID-19. But if we look specifically at digging into ivermectin real quick, we want to look at its function, and it has some valid function for helping prevent illness, just not COVID-19 yet, right? But if we dial into its prevention, it has been used for dengue virus, for HIV, in preventing replication of that virus. And if we look at the trend in the US with regard to ivermectin, it's dramatic in terms of number of prescriptions dispensed in the US for ivermectin. That's why we're talking about it, because we're upwards of almost 100,000 over month to month, right? And we know that our population will be considering, and if they are, we want to give them accurate information. So how does ivermectin work? Again, put on your heavy hat in terms of clinical, and we'll get through this. Hang with me. We've done this before. I know you'll hang with me this time as well. So with regard to COVID, we've talked about how those little spike proteins depicted here in pink help the virus get into the cells and then replicate to cause increased illness, right? And that process involves the virus just entering the cell to the extent that we've talked about it previously. Today, we're going to talk about now and focusing in on as it pertains to how ivermectin may work. It is the virus getting from the cell, the cytoplasm is called, actually into the area of the cell, the nucleus, where the virus genetics are then replicated, okay? That's the focal area here. And as we simplify that to this cartoon, we start with first denoting this is the outline of the nucleus for the cell. This is where the genetic material of the virus gets amplified, right, during disease state. And so what happens with regard to the normal process for disease for SARS-CoV-2, there's a complex that allows the SARS-CoV-2 to enter the cells. And that complex depicted here, IMP beta, has a component also called alpha, IMP alpha. Okay, this is an import protein, it's called, right? And this protein is normal in our cells. It helps us with cell replication and is a part of a healthy component, but it also can harbor a virus such as SARS-CoV-2 when it binds to it and usher it into the cell to replicate. And so what ivermectin does is it disrupts the bond between the alpha and the beta import protein, and that allows then a prevention of replication because the virus itself, even though it's in the cell, it's not actually able to get into the nucleus to reproduce, right? So that's the principle behind the use of ivermectin for different illnesses. But what we see, and as we examine this study that was conducted by Scientia Pharmaceutica and published years ago, not years ago, published last year in regards to SARS-CoV-2, they had a small clinical study showing that ivermectin did help hospitalized individuals in regards to lowering mortality and a shorter stay in the hospital, right? And so that's part of some of the data that is being reviewed by FDA and CDC in regards to whether or not ivermectin can be used safely from the perspective of helping our workforce decrease morbidity and mortality from impact to COVID-19, okay? And if we talk next then about another trend, boosters is front and center as well, right? So not only are we talking about clinical interventions like ivermectin, we want to talk about continued interventions to help prevent not just transmission, but continued morbidity and mortality from the impact of COVID-19. And so you may have seen this in the headlines where 1 million individuals here in the US have already been administered a booster, right? And this is from CDC data itself. So let's dig into this. Let's understand this trend here a little bit further. And so we can communicate to our workforce. So the CDC and FDA approved or supported additional doses of the Pfizer and Moderna vaccines, only the mRNA vaccines at this point in time, for a specific population, and that population are immunocompromised individuals. What that means is that if for whatever reason, an underlying condition that you may have can cause you not to have an adequate immune response, then FDA is saying, we want you to get a booster shot. And this was August 12th when FDA came out with this a statement here and approval for a recommendation for the booster, okay? As we look at then a joint statement from HHS, Health and Human Services, as well as FDA, NIH, they stated that clearly for those immune compromised individuals, a booster is recommended, and we are prepared to offer boosters to all Americans starting September 20th. And obviously we're into September now. And so we point this out because our employers, if you do have a workforce that's already vaccinated to the tune of, we've seen as high as 60%, then we need to be prepared for that population to receive boosters. And they may do it in the community, they may do it in a employer offered program. So we need to get ready for the US to start distributing these boosters starting September 20th, an important trend for us to be prepared for. And to answer any employees that may pose the question of when is this coming? Now, FDA hasn't, there may be some considerations that may slow down distribution after the 20th, but as of right now, it looks like everything's moving forward to hit this date for distribution broadly in the US. And this, again, is for all Americans, not only the immunocompromised at this point. So we want to answer the question now, right? There's all the hoopla and recommendations around, supporting a mandate in the workplace, but is it actually going to help, right? And so we want to talk about some of the aspects of ROI, return on investment, and health outcomes in the workplace for a vaccinated population. We won't expound fully in the interest of time for this presentation. We'll talk more about it for next month's presentation in terms of, and I'm purposely giving you a teaser here, but we want to get into some of the mechanics in regards to the benefit from a clinical outcome standpoint of vaccinations and considerations that will be asked by your populations around the mandate for a vaccine as well as the booster, right? One of them that has come up and asked over and over is a phenomenon called ADE. It's antibody dependent enhancement. Okay, and this phenomenon is something that may be playing out in the US right now as a result, or reflected in the higher numbers of deaths and severe illness in the population, and particularly the population that may have been exposed and recovered from COVID-19 and now being reinfected. Okay, and we know that it is likely something that is happening with the seropositivities that we reviewed earlier being high as a third of the population. And so what is ADE? Okay, we still have our immunology hat on here, right? Our heavy immunology hat. So we're gonna get into a little bit more of the immunology so we understand it briefly and can address it as we get the questions. All right, so roll with me here. So we're starting with, on the left-hand side here, an individual who's first infected by a SARS-CoV-2 or COVID-19 or receives a vaccination, right? We start here with the virus that then enters the cell via ACE2 receptor. We've talked about this before. And what likely in a recovery has happened is the antibodies have attached to that SARS-CoV-2 and they have destroyed the virus, and that individual then recovers from and is well after the infection of SARS-CoV-2 or COVID-19. But what happens in regard to the risk of ADE, the antibody-dependent enhancement, we see that antibodies, if we have enough of them in our system, that's the NAB titer here. That means you have a substantial number of antibodies to protect you, right? They attach to the virus itself when you're exposed again. This is a second exposure to SARS-CoV-2, and the virus is destroyed, right? But what we've talked about before, and why the booster is necessary, and why we want to mandate a vaccine even for individuals who have recovered from COVID-19 in the past, is that our antibody count wanes over time. It decreases, right? And 8 months is about the timeline in which we've seen clinically that phenomena occur. And what happens potentially when we're talking ADE potential, in that scenario, the low NAB titer, meaning your antibodies are not high enough to prevent illness, you still may have antibodies, as we're pointing out here, that bind to the virus itself, right, on the spike protein, but it's not sufficient enough to actually prevent the virus from entering the cell. And so the cell uptakes the virus and doesn't recognize that it's foreign and actually starts reproducing the virus itself, even more so than it may have before, because this antibody actually helps the cell recognize and enter, it helps the virus be recognized as not bad and enter the cell, right? And so you have an inefficient or not substantial immune response, replication of the virus, and potentially worse illness as a result of your second exposure to SARS-CoV-2. Now, again, this is postulated. This has not been proven out over and over in clinical published data. However, it's being studied, and we'll hopefully have the definitive results as we proceed in months' time. Now let's look at a different scenario, still regarding an ADE response that happens here in regards to an antibody having sufficient blocking of that virus, right? But in this case, the virus is mutated. So what are we talking about here? Different strains or different variants of the virus, a different S protein. This is Delta, right? And so if you have, even if you have sufficient blocking of the virus itself, either from natural immunity or from a vaccination, acquired immunity, those antibodies can still bind to receptors called Fc gamma R receptors. We won't go into detail of those receptors, but the process then causes the antibodies to bind to that receptor, and the virus itself is taken up by other immune cells, not your typical cells that reproduce the virus that live in your lungs. These are now, instead of those cells as in the previous depiction to the left, these cells are actual immune cells that reproduce the virus itself and leading to illness. Okay, and if likewise you have insufficient number of antibodies in terms of, or insufficient binding of those antibodies, meaning that the S protein is mutated enough that you don't have adequate binding of your existing antibodies to that protein, same result. You have uptake of the virus, the immune cells that normally would destroy the virus itself, then produces more viral particles, leading to more disease, right? And so this scenario could be playing out, and it is a consideration that we've been questioned on by those in the workforce, and we want to plainly say that it's possible, right? But it's not been proven. So it's not a reason to avoid the booster at this point in time. It's not a reason to avoid the vaccination at this time. And we know that those individuals who are being vaccinated, to the tune of, in case of Florida, right, 91% of individuals in the hospital with COVID-19 infections do not have a vaccination, have not been vaccinated, right? And so we know severe illness is prevented by the vaccine, and that you may experience more severe illness from just a recovery from COVID-19 itself. And this is the final thing we'll mention, and then we can take our immunology hats off here, okay? But it is another pathway in which people may experience more severe illness and be hospitalized as a result of antibodies being not sufficient to kill the virus. In this case, we're talking about a dengue virus, right? It causes dengue fever. And we know clearly we have enough evidence to show that dengue virus does cause ADE, right? Antibody-dependent enhancement. And what happens in this case, once you're infected once with dengue, you develop antibodies. If you're infected again with dengue, those antibodies do attach to the viral particles and then to that receptor I talked about before, the Fc gamma R receptor. But instead of destruction of or replication only of the viral particles, your body goes into this hyperinflammatory state. And that causes severe respiratory problems and can lead to death, right? And so that's another outcome that we want to mention from an ADE perspective. And then the other outcome is the one we just presented regarding SARS-CoV-2, where the viral load is replicated by the immune cells instead of destroying the viral particles. Okay, and so again, we got deep and heavy, but these are important things that we've been asked, and so we want to respond and distill these things for you so that, again, we're communicating accurately to our workforce. So what are some of the mechanics around the booster in regards to protecting from severe hospitalization and severe illness, that being the goal, right? And so our recommendation is don't only mandate the vaccine, but mandate the booster so that we can prevent hopefully these poor outcomes from happening. And then finally, the messaging we want to talk about is very succinct here because we know that there's a myriad of approaches that have been taken thus far, but it's still going to be knowing your population, specifically in the workforce, and what they may best respond to motivate them towards a vaccination, right? And it doesn't necessarily, your mandate doesn't necessarily need to be get vaccinated or else, right? Walmart and Disney did say that. But it can be what we presented before, where the NFL put in place repercussions of not being vaccinated should that impact negatively the player's ability to perform and play their craft, right? Where they have financial loss, both from a team and individual standpoint, okay? And other strategies here we've seen play out, for example, Delta Airlines instituting an increase in insurance premiums for anybody in the workforce to the tune of $200 a month for coverage, because on average, Delta reports, they spend $40,000 per hospitalization of an individual that is infected with COVID-19. And so to offset that risk from a business standpoint, they have now instituted top down this increase in premiums for health insurance coverage for their workforce. Again, not a mandate, but a strategy to promote vaccinations and to mitigate downside business risk from a workforce standpoint, right? And then if we talk finally about other messaging and other approaches, we want to question, as reported here in the journal Nature, forcing the issue of vaccinations nationwide, right? And the strategy that we contemplate basically is one where governments obviously can't mandate or can't force individuals to be vaccinated because of our freedoms that we're afforded, but they can put in place repercussions if individuals don't follow, right? And that literally translates to what we've seen play out over the decades of for example, kids not being able to participate in school if they're not vaccinated and don't have an exemption, right? And so we're seeing this exemption status play out for our employers. We're here as a partner to help you review those exemptions so that you can eliminate the risk of corporate practice of medicine, so to speak, regarding the determination of who's exempt and who's not. And your local providers should be able to help you with that as well. But certainly, we want the messaging to be clear that if it's not coming from the employer in terms of mandate, it may be coming in time, perhaps from our federal government. And we want to understand all the repercussions, not just of the vaccine itself, but also the booster, and the strategy can work. And so I want to leave you with a positive note that yes, the vaccines are still the way to go. Yes, the booster is still going to be the best bet for us to continue to minimize the effects from COVID-19. And so with that, I'll stop. I know we've gone quite some time here. We still have 14 minutes left. The last teaser is we will present on the cost of COVID. A teaser being, for example, if you are diabetic, poorly controlled A1C or sugars, and you get COVID, on average, that's going to cost the business, your employer, if they're self-insured, about $70,000, just under $70,000. If your A1Cs are better controlled and your sugars are better controlled, that number drops to about half, $30,000, just under $30,000. And then finally, if you don't have a history of diabetes, on average, it's about $14,000 for a COVID healthcare cost for the workforce. So those are some of the things we want to consider as we talk about how to mitigate downside business risk and the ROI. And we'll talk about that during our next presentation. So thank you, and we'll open it up to questions.
Thanks, Dr. Harris. Just to clarify, you had November on that last slide, but do you mean October 6th when we'll be back in a month?
I certainly do. That is my error. Sorry, jumping ahead in the future.
No problem. We can jump ahead. We have a ton of questions, so I'm going to jump right into them. Some of them we'll have to answer later. So the first one is related to the approaching flu season. We're hopeful our employee population will be interested in participating, but we're fearful the recommendation of a COVID vaccination or booster at the same time might make some employees reluctant to get both at the same. So what recommendations do you have as employers start to roll out and prepare for flu season?
Sure. So as with last flu season, we saw that flu, because we were wearing masks and everything, the incidence of flu went down, right? That's likely a causal association there. Yes, flu vaccines are still recommended, and no, there is no data to suggest that there's any downside risk for being vaccinated for flu and COVID at the same time. And in fact, we're likely to see an increase in the combo vaccines for COVID and flu. And so there's still a strong recommendation to get both COVID vaccinated and flu vaccine to help prevent both. And that makes it easier, as we talked about some time ago, prior to flu season before, for determining your risk level of having COVID should you have symptomatology, right? Where if you've been vaccinated for flu and vaccinated for COVID, again, there may be a different pathway with regard to your return to work process that is less arduous than if you are not vaccinated for either or only one. So those are the things we should consider and communicate.
Okay, and what types of side effects can we expect with the booster shot? for this person, the first shot wasn't bad. The second one made her pretty sick for a day or two. And I would add that what if you get a flu shot close to getting the booster shot or your first vaccination for COVID? What kinds of side effects might you expect?
Sure. So the typical side effects primarily, and by typical, I mean the most common side effect being soreness at the site of injection for the vaccine itself. That's by far the most common. The next then to consider is the symptoms of general malaise and the feeling tired frequently. That's malaise. And then some individuals will experience a little irritation, redness, erythema around the area of injection. The least risk is around the severe anaphylaxis. So again, if you do or have experienced a strong response to any vaccine, particularly COVID, talk about it with your physician, right? The impact of the COVID vaccine that we all have seen play out in terms of knocking you down for a couple of days, 48 hours, 72 hours, that still may play out, right? From a safety standpoint, there's no increased risk that FDA or CDC has published. But again, that is a potential side effect for some. And we want to, be transparent in communicating that. But again, there is no prohibition or limitation at receiving the COVID or the flu vaccine. From a side effect profile, it's not likely to increase risk for side effects because you're getting both in close proximity to each other.
Okay, that's interesting. Do you have any update on the booster for the J&J vaccine? This person says there's quite a few people in Waco, Texas, who got J&J, and they're wondering what the status is.
Sure. So, even though FDA has given a clear date, September 20th, for the mRNA vaccines, they've also unfortunately said they need more data around the J&J vaccine before they give a recommendation for boosters. So no date yet published by CDC or FDA, but they are likely to recommend boosters for J&J is what they've stated thus far. We just don't know when.
And I just wanted to mention that we just posted frequently asked questions on the booster, and we're monitoring these developments because they seem to be changing pretty much every day, and we're anticipating more information from the FDA and the CDC ACIP relatively soon. You mentioned that the R naught at the beginning of the pandemic was 3.5, but you didn't mention exactly what it is now, and this person was wondering.
Indeed. So if we go back here and look at the R naught for COVID-19, if you can still see my screen here. As of today, if you look at the August 29th date, the R naught here is just over 1. So it's under 1.5. A couple of days ago, it was over 1.5. But again, this is a rolling average here for R naught. And if we continue to trend up in terms of cases, we're likely to see this number go back up as well.
Okay, there's a couple questions about the variants. Are there any updates on the Lambda variant? Should we be concerned? Is it pretty much totally Delta variant right now? And what about the original strain of COVID in comparison to Delta? The percentage of cases we're seeing now are predominantly Delta or not?
Sure. So yes, by far and away, Delta has been for weeks more than 85% of new cases. As of today, it's virtually 100% now. If you look at the data, virtually 100% of all cases now are Delta. And that's just not here in the US, that's in the UK, that's abroad in multiple countries. So it is attributed to the Delta variant. In terms of the Lambda variant, the most recent data I've seen, and that's as of this week, is that the Lambda variant is increasing here in the US. There are a number of cases, over 1,000 cases at this point in time of Lambda. But the Lambda variant does not appear to be as easily transmissible as the Delta variant. And so the question still is it likely to blossom, so to speak, as the Delta variant has, and that's still pending. We know that Lambda does have some features of resistance to the vaccine, but that may be offset, if you would, by the decrease in transmission rate or ease of transmission. So we'll see where it's at. I believe Florida, Texas are right now the hardest hit by Lambda. The cases have increased in the low percentages, 5%, 3% in Alabama. But we'll continue to look at the impact of Lambda to see how it's going to go.
Okay, another question about boosters. What clinical trials have been conducted for boosters? How do booster contents differ as far as the dose and ingredients, et cetera? How are boosters studied and approved?
Sure, the same process as the original approval for the Pfizer and Moderna. And so way back when, and by way back when, I mean at the 1 year mark of the individuals who participated in the phase 3 clinical trials, which was December of last year, and I spoke with one of them out in California, a cardiologist. They started to participate in clinical trials for a booster for the Pfizer vaccine. And it was conducted very similar to the original phase 3 clinical study in terms of looking at safety and efficacy. And so all the data has looked beneficial in terms of it being minimal risk from a safety profile and benefiting individuals from a extension of their immune and limiting susceptibility standpoint for reinfection as well as severe illness and hospitalization. So again, no difference in the formulation of the makeup. The boosters are at this point coming from, it appears, our stockpile of vaccines that we've accumulated here in the US. And that will likely be the case abroad as well. But the pharmaceuticals have stated that the test that they've conducted for the vaccine still is efficacious to the extent that we've seen for Delta with Lambda as well, from a standpoint of prevention of hospitalization and severity of illness.
Okay. Again, we have to remind everyone we only have 3 minutes left, so we only have time for one more question, but do check back on our website, and I'll be following up with Dr. Harris to make sure all your questions get answered. The last 2 questions are related to tests. We're managing COVID per federal government requirements and CDC guidelines. CDC recommends that fully vaccinated people who have a close contact with a known COVID case should not quarantine, but should have a test 3 to 5 days after exposure and should quarantine if test results are positive or if they have symptoms. Should this be a rapid test or should it be a lab analysis test, meaning rapid versus PCR 2 to 3 days? And the other question is also asking about what's the consistent approach for that type of testing?
Sure. So I will give and respond according to a consensus the physicians at WorkCare have in regards to how to approach and what we've been recommending to our clients. This goes beyond any recommendation from CDC because CDC, frankly, doesn't address specifically which tests to use, rapid or PCR. We suggest and recommend, yes, PCR utilization for any exposure, any positive exposure or known exposure of an individual on a case-by-case scenario. On a broader scale, let's say you have an exposure of an individual in, for a workforce of, let's say 50 folks in a room, we have seen rapid tests utilized for a large number of people to be screened for potential infection after an individual positive for a scenario, again, of a positive exposure, meaning that individuals weren't wearing masks and they spent 10 minutes or more in proximity within 6 feet of that positive person. But in general, case by case, a positive exposure would require a PCR. It says 3 to 5 days. We've seen a lot of breakthrough infections and individuals who become positive after that 3-day mark, so that we've changed our recommendation to 5 days. So at 5 days, doing a PCR to rule out infection is the best practice that we recommend at this point in time. There's still a myriad of types of PCR tests. We don't go as far as to specify which one, other than try to understand the efficacy of that PCR test, because there still is a lot of variability out there with regard to false positives, false negatives, et cetera, sensitivity and specificity. So that, in brief, is our recommendation. And I know we're running out of time, so I'll stop there.
Okay, yeah, the commenter says the concern over the rapid test is that the employee may be contagious but not know it if they rely on the COVID rapid test that just checks for the antigen. So the recommendation to get PCR to verify makes sense in that case. Okay, well, wow, I wish we always had more time, but we're out of time for now, but we'll be checking back with you on October 6th. And keep in touch with us if you have additional questions. We're happy to address them in the interim, and we're monitoring things as they evolve. So do check back with us and keep an eye on our website, because we keep updates on our COVID page. Thank you so much, Dr. Harris. As always, we really appreciate the information and geeking out on your clinical findings. It's really interesting. Excellent. So thanks again.
Absolutely.
Take care, everybody.
Thank you, Karen. Thanks, everyone. Take care, and always, God bless.